Hi everyone, my name is Fatima Wakil and I'm an associate professor in the College of Health. Thank you so much for joining us today for our Population Health Colloquium Series, which is a bi-weekly series hosted by the College of Health. This faculty organized series have continued throughout the summer and have focused on COVID-19, examining the most vulnerable populations, social determinants, and shining a light on long-standing inequities. Today we have the last webinar for the summer. In today's webinar, the panelists will discuss how Native peoples of the Americas are being greatly affected by the COVID-19 pandemic. The morbidity and mortality rates of some Native communities rival that of New York and New Jersey. However, the effects of the pandemic on Native communities has received little mainstream media coverage, and some US states are not even counting Native peoples in their COVID-19 statistics. This webinar will look at some of the issues in Native communities because of the COVID-19 pandemic. For those who are listening, please send your questions to us using the Q&A feature, and we will address these during the second half of the webinar. Next slide, please. I am very pleased to introduce our moderators for the panel today, Dr. Christine Daly and Dr. Sean Daly. Dr. Christine Daly is a professor in the College of Health and co-director for the Institute of Indigenous Studies. Dr. Daly has a PhD in Applied Medical Anthropology and a minor in Cytotechnology, an MA in Medical Anthropology, SM in Health and Social Behavior, and a BA in Anthropology. She's a mixed methodologist and a community-based participatory researcher by training and has been working with American Indian communities since her undergraduate career. Dr. Sean Daly is a professor in the College of Health and co-director of the Institute of Indigenous Studies. Dr. Daly is an applied sociocultural anthropologist and ethnographer with expertise in American Indian studies, community-based participatory research, and cultural tailoring. Much of his work lies at the intersection of religion, spirituality, and health. He has been working with Native people since 1995 and has worked with Native communities in Arizona, Connecticut, Kansas, Montana, New Mexico, and South Dakota, as well as several other states. Chris and Sean, please take it away.
Thank you, Fatima. As Fatima said, I'm Sean Daly. I'm going to get us started off today. And what I'd like to do is introduce our panel. And in full disclosure, the panel is basically a group of friends and colleagues. Chris and I managed to get together to talk about COVID in Native communities. So our first panelist is Justin Begay. Justin's a member of the Navajo Nation of Arizona, New Mexico, and Utah. He's a research scientist with the Institute for Indigenous Studies here at Lehigh. His specialty is smoking cessation, and he's the lead facilitator with one of our programs called All Nations Breath of Life. On a personal note, I've known Justin for many years, and he's been working with us for quite some time now. We have Justin's sister, Angelina Dinetto. She is down in Tuba City on the Navajo reservation. She is a COVID survivor, and we'll talk about her experiences a little bit later as we go along. Also from Navajo Nation, we have Joshua Allison Burbank. I should say Dr. Joshua Allison Burbank, as Joshua just got his PhD recently. He's a member of the Navajo Nation and Acoma Pueblo in New Mexico. He just got his doctorate in speech and language pathology from the University of Kansas. But more recently, he's been working at Shiprock Medical Center on the Navajo Res as a frontline worker, doing assessment, intake and assessment for COVID-19. We also have Jordan Gunville. Jordan is a PhD student in the Health Policy and Management program at the University of Kansas. She's from the Cheyenne River Sioux Tribe in South Dakota. She does a lot on Native maternal child health, as well as education and outreach to Native communities. We have River Gunville. River is also from the Cheyenne River Sioux Tribe in South Dakota. She recently graduated from Creighton University with a BA in medical anthropology. Depending on the day of the week, she's either getting her PhD or going to med school. She has been working with us for a while now, doing community outreach, community empowerment, and works on our smoking cessation grant as well. And last but not least, we have Joe Pacheco. Joe is a member of the Quechua tribe from Bolivia. He's an ABD doctoral student in health policy and management at the University of Kansas Medical Center. Joe has done quite a bit in native environmental issues, native cancer research, and he is a senior research scientist at the Institute for Indigenous Studies at Lehigh University. And I also skipped in the introduction mentioning that both Jordan and River also are research scientists in the Institute for Indigenous Studies at Lehigh. Did I miss anyone? Chris, you want to introduce yourself?
Hi, so I'm Chris Daly. I'm professor at the College of Health and the co-director of the Institute for Indigenous Studies. I've been working with Native communities for about 25 years now. My specialty is primarily any type of prevention research, community-based participatory research, working with Native communities. And a little bit later, I'll talk to you about some of the projects that we're working on specifically with COVID-19. But I'd like to get to the panelists. I will mention that we have one panelist who was unfortunately unable to join us. She's another COVID survivor from Tuba City, who is probably mentioned on one of these slides that we missed, but she was unable to join us today. She has a follow-up medical appointment, unfortunately.
Hopefully she'll be able to join us for the last few minutes, so we'll see what happens. So I want to start off with some basic statistics. So there's a publication out there called Indian Country Today, for those who are familiar with it. If you're not familiar with it, it's a daily website and newspaper that comes out on issues affecting Indian country. And their last update was July 28th. And according to their website, there were over 15,000 cases and 622 deaths in Indian country. The four most affected tribes were Navajo Nation, with over 9,000 positive cases and over 400 deaths. White Mountain Apache of Arizona with 2,100 positive cases and 31 deaths. The Mississippi Band of Choctaw with 1,000 cases and 70 deaths. And Zuni Pueblo in New Mexico with 431 positive cases and 22 deaths. The majority of cases we're seeing in Indian country are in the Southwest, particularly Arizona and New Mexico. And one of the issues, which I know Chris will touch on a little bit later, is that the numbers we're seeing are likely very underestimated because a lot of these numbers are numbers we're getting through tribal clinics and Indian health services. These are not counting Native people who are going to healthcare centers in urban areas or going to private hospitals, clinics, things like that. Likewise, these numbers often don't reflect tribal members living off of reservations. And today, over 50% of Native people live off of reservations. Likewise, due to how slow information is to get into reporting agencies sometimes, there's also probably a deficit in reporting and information because of that. On top of that, rurality, isolation, cultural social barriers, lack of resources at the tribal, community, and family levels are really contributing to the explosion of COVID in Native communities. Chris, did you want to talk a little bit about socioeconomic status, things like that?
Well, one thing to understand about reservation communities is that these are some of the poorest communities in the United States. Out of the top 5 counties in terms of poverty rates, 4 of the 5 are American Indian reservations. 3 of those are actually in South Dakota, and then the other in Arizona. So when you have poverty, you obviously have poorer access to healthcare and poorer health in general. And so when you see socioeconomic status thrown in there as well, you tend to see compounding results. So you have people who struggle to get access to care, struggle to be able to care for themselves by getting medications, by being able to pay for those medications, and that sort of compounds any issue that you're going to hear about. So one thing you'll be hearing about today from our panelists is the poverty on the reservations and how that is affecting and impacting COVID on those reservations. You'll see much higher death rates and a lot of comorbid conditions that are contributing to higher death rates. You'll also see a lot of problems with just people being able to access getting to the doctor. So that also contributes to those rates not being really numbers you can trust. If you have a lot of people who can't get to the clinic, we just don't know how many people actually have COVID, and we don't know how many people are dying from COVID. So because of that, you really don't see the real problem with COVID or any other health issue on a reservation because you just don't get the numbers that are accurate.
Okay, so I think what we're going to do is we're going to start with Navajo Nation. So for those of you not familiar with Navajo Nation, the reservation lies in portions of New Mexico, Arizona, and Utah. It's roughly 27,000 square miles and is larger than 10 of the 50 states in the US. The per capita income on the reservation is about $7,200 per year, and approximately 50% of Navajos living on the reservation live below the US federal poverty line, which is about 11,800 for one person. About 43% of the reservation's population is unemployed. Running water, electricity, things like that still lack on a significant portion of the reservation. The Navajo Nation Department of Health has been tasked with following the outbreak on the reservation. In the intro, it was mentioned that in certain Indian communities, the rates rival that of New York and New Jersey. And in mid-May, the Navajo Nation had 2,300 positive cases per 100,000 people. That was the highest rate in the US. It was higher than New York and New Jersey. The Navajo Nation President, Jonathan Nez, declared a state of emergency initially on March 13th and has had to extend it 6 times now. Several lockdowns have been initiated, particularly weekend lockdowns. And my understanding is right now there's a daily lockdown from 8 p.m. to 5 a.m. COVID-19 patients have to be transferred quite often off the reservation to surrounding cities, Flagstaff, Phoenix, Gallup, Albuquerque, places like that. So with that said, I'm actually going to start with you, Joshua, if you don't mind, since you are at a healthcare facility. You want to talk a little bit about what you've seen and experienced, because one of the things I want people to take away from this is the personal angle. I want people to get away from the statistics, get away from the numbers, and see how this is actually affecting Native people in real life.
Sure. I'll tell you, everyone. John, my internet is kind of spotty, so call me on my cell phone if you lose me, okay? So that way I know, because it's kind of freezing up on my end. But it's good to join you all. Again, my name is Joshua Allison Burbank. I'm joining you from Shiprock, New Mexico, which is near the Four Corners area. I work at an Indian Health Service facility called Northern Navajo Medical Center. And what I'm saying today is kind of is personal, and it's not meant to represent Indian Health Services or the U.S. Health and Human Services. This is my experience as a tribal member and as a person living in the community here, as well as being a healthcare provider. But it's been an interesting past few months. Up until last week, I was working outside in our car screening and triage, where the screening for COVID patients was actually happening, as well as the testing. And so what has happened over the past few months is a constant change, constant response to viral activity, whether it's increased or gone down, but also the various attempts, whether it's been government or healthcare or tribal attempts to try to manage and meet the needs of individuals who have been forced to stay in one spot, and to try to control this many tribal members has been quite difficult and quite challenging, and what has contributed to that high infection rate. But what I've seen over the past few months is a lot of struggle, a lot of difficulty, a lot of a need for stepping up to the plate across all healthcare facilities. I'm a speech language pathologist. Most of my training is in global developmental delay and working with young children. And when the pandemic hit Navajo Nation, I found myself working alongside emergency department providers to try to meet the needs of this demand for testing, and just there were so many sick people. And then on the other end, there were young children who schools were greatly impacted by the immediate shutdown and closure of all schools. And you heard about the socioeconomics that impact access to internet, impact access to technology, and all those factors were intensified when everyone was sent back home, and virtual learning and our home programs were trying to be implemented. And it was across the lifespan. You had the virus hitting individuals and getting people sick. And then you had those other secondary effects on the children, on the mental health of those who have been forced to stay home, but also we're very collective people. We like to be with one another. And so that piece there of not being able to have ceremonies, not being able to have tribal fairs, parades, no traditional practices, no religious gatherings, nothing, no family events, that really messed with the community's health in the way that we're not allowed to practice those traditional protective factors that are so important for cultural and language preservation and just kind of overall well-being. So, I mean, I could go on and talk about what my journey's been like over the past few months. I've worked with children and adults and elderly who have COVID. And now what we're seeing is a higher survival rate now. And so the individuals that are sent off to the hospital very early on were not coming back. Once they were intubated and sent out, they weren't coming back. But now many are surviving and they're coming back with pretty intense need for physical deconditioning and speech and language therapy and mental health services to help process these traumatic experiences. And so this is my story. This is what I've seen over the past few months up here in Shiprock, and I'm at the very tip. I'm at the very northeast corner of the Navajo Nation. But I did want to. There's all these challenging things that have been happening, but there's also been some great things happening with children and families being allowed and being forced to be home with one another. There's more interaction happening with parents and caregivers and children. I actually see a resurgence of some traditional practices, whether it's farming, celebrating of the family unit, building up the infrastructure within the family, which is a really great thing to see. I mean, I think all these different factors of having to work a job or send children off to school really takes away from that culture and language piece. And so it's been very challenging to manage and respond to COVID-19, but I also see some really positive thing as an outcome. And maybe I think that might have long-term implications on what we prioritize in healthcare and education. But I'll stop there, and I can answer more questions or jump in more, but I want to give time for other members of the Navajo Nation, other members on this panel as well. But thank you.
Thanks, Josh. Angelina, would you like to piggyback off what Josh said? Because I know you were one of the you were one of the people that get COVID early in this. So if you're willing, would you tell a little bit about your experience?
Yeah, hi, my name is Angelina Dinetto. I'm from Tuba City, Arizona. My father's family is from Shiprock, New Mexico. We as a family, me, my husband, my mother, we were one of the main group of people who were first affected when the COVID hit. A lot of my in-laws were the ones that were affected more. They had a church gathering or revival at my mother-in-law's sister's land, and someone from the original site where they had a church gathering came to her revival, and then they infected everybody at the revival. So it wasn't until I would say, I don't know, maybe with within 2 weeks, we got really sick. I started having a lot of really bad symptoms, but it affected my mother-in-law, her sister, and the sister's son as well, who all got it at the gathering. And then they had another sister who got it, but unfortunately, she was able to survive. But my mother-in-law, her sister, and the nephew, they all passed on from the COVID, all within a week. And then after the aunt-in-law, her name was Mary Ann Welch, and then her son, they passed a day from each other. My mother-in-law was flown out to Flagstaff Medical Center along with Mary Ann and Larry. My mother-in-law's name is Eva Dinetto. She was there for a week and a half at FMC. She had developed really, when I went over to her house, she was really incoherent. She didn't know where she really was. I had to help her into the restroom, and I just told her family, her kids, and I said, you know what, you need to call an ambulance right now. There's just no way that she's going to make it into the ride. So we called an ambulance, and her vitals, her oxygen level was at 56%. She had a fever of 103, and you could hear her labored breathing. I'm a nursing assistant, and I've been through a lot of different viruses, so I understand what everything is. And so when she got into the ambulance, they had to help her, of course. And then her sister, Mary Ann, was already flown out that morning to FMC. And then we got a call from Navajo Mountain that the other sister wasn't feeling very well. So me and my husband drove out there. We wore our masks and we had sanitizer. And we literally drove an hour and a half out to Navajo Mountain to pick her up. And she was just really weak. And you could tell she had really, her fever, she was hot, extremely hot. And so he had to pick her up and put her in the ride. And the nearest hospital is 45 minutes away, which is a small little clinic out in Navajo Mountain. And the biggest hospital we have is in Tuba City. So we had no choice but to drive her all the way to up to Tuba City. And that's when I had found out that my mother-in-law was being intubated and had flown out to FMC. The other aunt, sister that we brought in, they just admitted her. Her vitals weren't that bad, but her oxygen level was at 85%. So it wasn't enough to fly her out. So they kept her at the hospital. And then while all of that was going on, we got another call from his cousin, Mary Ann's son, Larry, saying that he almost passed out at the horse corral. And so me and my husband, again, this was the next day, and we drove out there, and he was extremely pale. He was sweating, and his body was hot, and he had he said that he couldn't breathe. So we barely got him into our ride, and we drove him out. And they didn't have any room in the hospital, in the emergency room. So they made us wait in the ride with him. And they took his vitals out here in our ride. And his oxygen level was also at 56%. So they had to wait until they flew out another person in the ER. And then they finally got him in there. And they took one part of the hospital of the emergency just for COVID related, and it was only 3 of them. 4 of them actually, 4 rooms for anybody who may have COVID. So it was with his already health issues that he's already had in the past with his respiratory and him being a veteran and diabetic and all of that, he was just not going to come out of it. The hospital, he was actually 100% reliable on the oxygen. So then when everybody was admitted, my husband got sick. He had really bad headaches. He was coughing a lot. He had a hard time breathing. Him being diabetic as well. I ended up making him go in, and he ended up staying in the hospital. His oxygen level was at 82%, and he was there for a week and a half. And we had found that his other sister was admitted as well in the same respiratory unit, and then my brother-in-law, his wife, was admitted also for the same thing, and they were all in the hospital together for a week and a half. Fortunately, they recovered, but the other sister, I'm sorry, it's been really hard. She has a 7-year-old disabled son. She didn't want to leave him. She was really, really sick. And she didn't want to go in. I kept telling her and telling her to come in. And so I took her in the first time, and she was extremely weak, and she managed to finally get in. But then I got a call later on that evening from her that they were releasing her. And I was really shocked, and because she was just really bad. Her oxygen level was like 70, but they sent her home. And then the next day, the other sister, my sister-in-law's partner, called an ambulance, and they got her in, and she was there for a while as well. They had her in the ICU. And at that time, we had found out that my mother-in-law wasn't going to make it, and so we had her last goodbyes, and everybody called. Of course, we couldn't be at FMC. We couldn't be there to hold her hand or be there in general, and we had to just make calls. And I was the one that was calling twice a day in the morning and at night to get an update. How's her vitals? How's her oxygen level? Anything new? And of course, nothing has changed. And then my husband and my both sisters-in-laws were finally able to get out. And then they were given different kind of drugs. My husband was given that hydrochloroquine, and it was just experimental. And he said it helped him breathe a lot better. And they gave him steroid injections, and it did help him a lot. I mean, from when he went in and to when he came out, his vitals were at 98% when he left. So, unfortunately, the night that we said our goodbyes to our mother-in-law because they were going to go ahead and take her off the ventilation, the next morning, we were just waiting for one more call from the other brother in Texas. Unfortunately, he was incarcerated. He's incarcerated, so they had a hard time trying to get him to get somebody. And with the whole COVID situation, the prison was on lockdown. So we had a hard time trying to get through to anybody for him to say his last goodbye. And he did say his last goodbye. And then that night, on April 11th, or that morning, I got a call from the hospital. By then, I was really still having a hard time breathing. I was coughing. I just really bad body aches and really bad headache. And that morning, I got a call from the hospital ICU. I couldn't understand her very well. And she said that, that my sister-in-law, Gloria, didn't want to be put on a ventilator. And I assumed in my mind, for some reason, I thought that she had already been put on the ventilator. They went ahead and made that decision. But the nurse said, no, unfortunately, she passed away in the night unexpectedly. Or early, around 12:30 in the morning. And then, that was a really big shock for us because she had texted and emailed us a picture of her eating sherbet ice cream, which she was really happy about. So it's just, we all had the same symptoms, but some of them didn't have all the symptoms. My husband had the shortness of breath. He had the headaches, the body aches, the coughing. He was having problems with his heart. My sister-in-law, hers was really bad. She had really bad respiratory problems. She couldn't breathe. She was just really weak. And I think we all had the same exact symptoms and more, everybody else was more than what I had. So there's just a lot of coughing, a lot of headaches, body aches. Some of us, our oxygen level wasn't as bad enough to get admitted. I mean, the lowest mine ever got was 92%. So that's just how the situation is. And then my mother, when my sister-in-law, when she passed away, that morning, a few hours later, my mother-in-law passed away. And so we had to do a lot of trying to figure out everything. We weren't too sure what to do. And then because of the whole COVID situation, we were not allowed to have a traditional funeral for them. We couldn't even see the body. The mortician had said that they couldn't even open the body bag when they brought them back. They had to keep them in there. Any possessions they had on them, they had to be buried with it. So they went straight from the body bag, staying in the body bag, into the coffin. But we, as a family, decided to let them do a cremation. And so we have everything over at the house, except for Larry. He was buried in a veteran cemetery in Belmont, Arizona. So that's kind of the situation of our situation right now. We've all recovered, me, my husband. Our 8-year-old daughter may have gotten it, but she had no symptoms whatsoever. She didn't have anything, actually. She was asymptomatic. She was direct contact with all of us. And I know that we've all recovered. My mother, unfortunately, was in the hospital for 3 weeks, almost 4 weeks, a month. She was really weak. She was just having a hard time breathing, and she was still doing chopping wood all up until I called an ambulance. The ambulance came, and her oxygen level was at 82%, and they got her in, and they didn't send her out. Her oxygen wasn't so bad. She was put in the regular respiratory unit, and she didn't need to be in ICU. And they did different experiments, I guess. They've given her hydroxychloroquine too, but it didn't have any effect on her. So they tried getting her to lie on her stomach, which she told me that was a lot better. She was able to breathe a lot better. They would do that several times a day. She would be on her stomach for an hour. And then she couldn't move. She had a hard time getting up. She was sleeping a lot. Her oxygen level kind of fluctuated between 80 to 90. And so all the experimental things that they were doing for her, the only thing that worked was the laying on the stomach and helping her breathe a lot better. So she did finally recover after 3.5 weeks, but due to her being so sick and being in bed all the time, she did have to have physical therapy at home. And they did bring a physical therapist that came from Page, and he was there for several days, 3 days a week, and she covered. Unfortunately, we do have some lingering effects. I heard that hair falling out, which mine has been doing. My mother's hair has been falling out. Also, we have been having a hard time with memory situations, just simple things that are, I couldn't even remember what some of the car parts in the vehicle was. So it kind of comes and goes. And we haven't had any symptoms. We have been out and about, but we always wear our masks. And we do have the sanitizer, which we keep with us 24/7. And so that's kind of the situation that we have dealt with. Within the last couple of days, we've been really missing my in-laws a lot. And my 7-year-old nephew is disabled. He's also on a feeding tube. And he doesn't know that his mom's gone. But we do play, my sister-in-law and her partner plays videos and sounds of his mother, Gloria, through her phone, and he responds to that. So it's really heartbreaking that he doesn't know that his mom is gone. But we keep his memory of her with the videos and the sounds. He's non-responsive, non-movement, but he can move his eyes back and forth. And he knows when he's there, or he knows that hears his mom's voice. So that's kind of the situation that we're dealing with. Everybody, I believe that all my nephews and nieces, my brother-in-law's kids also got virus, but they were asymptomatic as well. They didn't get any symptoms. And they have a 2-year-old Down syndrome little girl. And they were really careful about getting visitors, making sure nobody came, washed their hands. So she was asymptomatic as well. So everybody's a lot better and recovered, and we're doing a lot better, and we've seen it firsthand. We've felt it.
Hey Angie, it's me. We're short on time. I think we need to get to the other panelists. So thank you for sharing your story, and I will forego my part until probably the end, if at all. So we can keep moving. Sean.
Okay, thank you.
Thank you, Justin. Thank you, Angelina. I'm going to jump to River and Jordan. If you're not familiar with Cheyenne River Sioux Tribe, their reservation is up in central South Dakota. It's about the size of the state of Connecticut, so it's a sizable reservation. But similar to Navajo, it lacks a lot of the infrastructure needed. It has 2 ambulances to serve the whole reservation. My understanding is the main hospital in Eagle Butte doesn't even have a respiratory therapist. So if you're dealing with COVID, that's a problem. Same thing, I think they only have 4 ventilators. The tribe set up checkpoints to keep people coming onto the reservation to kind of manage movement in and out to keep COVID out. And they were called out by the federal government. It was all over the news a few weeks ago. The Bureau of Indian Affairs, as well as Kristi Noem, the governor of South Dakota, tried to step in and stop the tribe from protecting itself, and it kind of became an issue. Fortunately, Cheyenne River has managed, for the most part, to not be affected like some of the groups in the Southwest. However, my understanding is recently you had your first death, and it's starting to get a little bigger there. If you guys want to chime in on that.
Sure, I'll go ahead and go first. So hi, thank you for having me and bringing light to this topic. It's very important that we are able to speak on these inequities and injustice in our communities, and this is how we really address health quality for our people as a whole. So with that being said, as Dr. Daly did mention, that we have border checkpoints, health checkpoints put in place on the reservation boundaries. And the purpose of this is they do allow people to go through. It's just more of, well, they do stop people, but if there's border for farmers, for example, living, they are able to go and continue that agriculture responsibilities that they have. But because of this checkpoint, when we first had our really big breakout, as you heard some of the Navajo Nation members speak about, our people being a collective whole, and we're very tight-knit people. And so once, you know, we have multiple families living in one household, so because of these checkpoints, they are able to kind of detect who's coming in and out, and really where this kind of some public health contact tracing, and really get ahead in kind of get ahead of the virus and contain it as best as they possibly can. So the border patrol, the border checkpoints, you know, you know, it was a really hard time for our tribe, because the governor wasn't really being supportive. She was, and then she would go back. And so it just really makes it challenging, because as you heard, that we have a lot of disparities, which makes it really challenging trying to focus on kind of the issue and have that other outside force. But I guess our biggest issue right now is kind of the policies and the mandations, you know, the sovereignty that our tribe is, their sovereignty rights that they are trying to really enforce to protect our people, because as Dr. Daly mentioned, we do not have a lot of ventilators. So once it does hit our community, it will hit our community. And we, our tribal Chairman Frazier, he does weekly updates through the reservation radio. And so he often referred to our landmass being similar to Navajo Nation. So we kind of used them as almost a model to kind of how we would be able to prevent it in our communities. So since we're short on time, I will let River go ahead and speak. Thank you.
I do want to piggyback on something you said, Jordan, for the viewers who may not be aware. Your tribe was letting people through. It wasn't that they weren't letting people through. They were just testing them to make sure they weren't exhibiting symptoms of COVID.
Yeah, and they weren't testing them. They were just saying, have you been exposed? Just to kind of, and where are you going? Yeah, and so there was a lot of false reporting from the state, so that it has been very complicated.
River, do you want to add to anything Jordan said?
Yeah, I can talk about how that also relates to another issue that's going on simultaneously, or kind of simultaneously, as the pandemic, which is the issue of the pipelines. So let me introduce myself first. Hamadakapi, Abentu Washte, Chante Washte, Nape Chusapi, Nagi Kasapawi Amacha Pikusto, Ma Mini Koju Lakota Na Wakpa Washte Imataha. So greetings everyone, my name is River Gunville. As Sean said, I'm from the Cheyenne River Reservation. And like I said, there's another underlying thing that's happening on top of the pandemic, which is the Keystone Pipeline. That it is the Keystone Pipeline's 1,179 mile pipeline that would run from the sands of Alberta, Canada to Sealy City, Nebraska. And it is estimated to carry 830,000 barrels of oil each day. So how is this like related? Well, the highways of the Cheyenne River Sioux Tribe are monitoring connect several potential construction sites of the proposed pipeline route, which skirts tribal lands. And our tribal chairman, Harold Frazier, has been very outspoken against pipeline, especially the Dakota Access Pipeline, which was happening around like 2016. And the Cheyenne River Sioux Tribe, the pipeline is proposed to cross upriver from the reservation. So it's a really big deal. When and if it does get implemented, it's going to impact our people, our water, our land. And another thing that comes with the pipeline is the issue of man camps. And man camps are basically temporary housing for the workers who work on the pipeline. And there has been the relationship between extractive industries and violence against women and girls, particularly Indigenous women, has been well documented. There's several reports and studies that suggest there's a correlation between sexual violence and sex trafficking around these areas. So that not only does this pipeline impose like environmental hazards and dangers, it also puts Native women on Cheyenne River and Native women around in these surrounding areas in danger and at risk for sex trafficking and sex exploitation and missing, and the potential to become missing and murdered.
And I know it had been brought up in several things I've seen online that the man camps would be incubators for COVID. And I know there was a lot of concern about that as well, the close quarters and things like that. Impossible to socially distance in a man camp or in a fracking site or extraction site. So I had seen several things being brought up about that. So for the sake of time, I want to get to Joe and talk a little bit about what's going on in Bolivia. Joe is of the Quechua people. They are the indigenous peoples of Bolivia, Ecuador, Peru, up in the high mountains of the Andes there. A lot of reports online aren't reporting about what's going on there. Before this, we started, Joe and I were talking about how the numbers are probably very underestimated. There's been reports that the Quechua peoples aren't being as greatly affected because of the high elevation in which they live, things like that. Joe, I'll turn it over to you and let you talk a little bit about what's going on down there and the underreporting going on.
All right, well, thank you. And I'll speak fast. And if you guys have questions, then we can answer them later. I just want to make sure that you guys have time to get your questions answered. So if you guys don't know the geography of South America, Bolivia is the heart of South America, and it's one of only 2 countries that do not have a border of the ocean. And so Bolivia's people are very diverse. There's about 36 different native groups. Quechua is the largest, followed by the Aymara Nation. And so when I talk about the native population, I'm going to use kind of the common terms that they use. So the people are called campesinos, and that's kind of derived from working the land. But because of political reasons, a new variation of describing Native people has emerged as the Native people have been brought into the cities. And so now they are considered city Vinos. So they're the Native people that live in the city. So what is currently going on is that the cities that are densely populated are having high rates of COVID. So one of the biggest cities down there that has biggest growth is Santa Cruz. So Santa Cruz is kind of similar to what we have in Miami. So it's the hottest area in Bolivia. And so they're called departments. And then each department has different providences. So you think of the city center as kind of the cluster of where people gather, and then the provinces are like small towns from what we're kind of exposed to in the United States. And another thing that is happening now is in La Paz, which is one of the capitals for the administration side of Bolivia, is seeing a huge increase. They've been jumping up about 50% a day. And that is very kind of worrisome, because they thought that maybe the high altitude of La Paz being one of the highest capitals in the world, which if you want to compare it, you think of Denver being the mile high city. Now think of two Denvers, because La Paz is about 2 miles above sea level, a little over 2 miles. So they're seeing a huge increase. But one thing that is, I think, helped out the Bolivians is that they are one of the least population density is the lowest of all the American countries. And so if you compare it to Bolivia, has about 11 people per a square kilometer. And if you look at like El Salvador, they have like 300 people per square kilometer. So that's, you can kind of see population density has helped them out with the providences. And the other issue is that a lot of people are dying because of COVID, but there's been a lack of other supplies being able to get to people with needs that have other medical ailments. And so what's not really being reported in the media is how many people are dying because of the lack of medication being offered. All the hospitals are filled. They don't have infrastructure to support the people that are getting sick. And so that is another impact that they are seeing. And so the outskirts getting to the campesinos out in the country is a lot harder when they don't have the supply of gas or the medicine to get to them. So that is kind of the situation in Bolivia. And the way that they're trying to control it is that they, based off their state ID, that means that what days you can go out. So if you think of your social security number, that's kind of what they have, and they carry that around. So if your number ends in an even number, you can go out Monday, Wednesday, from roughly 8 a.m. to 2 p.m. And then if you're an odd number, you can go out Tuesday, Thursday. Other than that, you need to stay at home or you'll get arrested and reprimanded. And I'm not quite sure what the punishments are there. My family members didn't really get into that. So I'll go ahead and stop there and pass it on, so that way we have time for your guys' questions.
Actually, Chris, did you want to talk about what you wanted to bring up about what's going on at Lehigh right now?
Sure. So one of the things to think about is that the take-home message here is that COVID-19 is hitting poor communities more than other communities. And Native communities, unfortunately, are overrepresented in lower SES communities, both here in the United States and really around the world. So you hear the example from Bolivia. This is true really throughout the world. So what happens then is you have more people getting the disease, more people dying from the disease, and it's really because of a lack of resources. So there are some of us who work in this area here at Lehigh who are trying to do something about this. I always hate to end on all of the negative notes about things. So just to mention some of the things we're trying to do to help in this area. We've put together some educational materials using, it's information that is available on many different websites and from many different organizations, but we're trying to translate that information into different Native languages and get it out to people who are monolingual speakers from a variety of different tribes and also down in South America. So we're trying to get that information out there. We're also distributing masks. We've distributed 2,500 masks so far, and if there is anybody out there that has masks or other personal protective equipment you would like to donate, we can get them where they are needed. So we are actively looking for people who are willing to donate. These need to be distributed. people do not have the money to buy a mask. I know that sounds odd to a lot of people who come from a higher socioeconomic status, but people simply don't have the money and don't have the ability to get the simple personal protective equipment that is needed. So we're trying to do that. We're also collecting information about the various tribal policies that have been implemented to try to get that information out to other tribes so that they can see how things might be done. And we're looking at how community members are responding to this. We're trying to collect stories in the hopes of publishing a book to kind of get the native face of COVID-19, but also to help people understand that there's a lot of resilience going on in Native communities. People are bringing back traditional activities to help them through this pandemic and to work together as a family to get through this pandemic. And that's a really important piece that is often not available to people, to understand that there is a huge amount of resilience in Native communities to fight things like this. And so we're trying to collect those kinds of stories to get them out there to people in an effort to just let people know that they're not alone. When you live in a very rural area, might not have the ability to connect to the internet as easily, you need to know that you're not alone. And so we're using our networks and trying to get information out to different people. You know, it's tough when we're in a situation like this where everyone in the world is being affected and Native communities are also being affected. And oftentimes when you have small populations, they kind of get forgotten. And we don't want to allow that to happen to Native communities in COVID. We hear so much about what's happening in urban communities. We hear so much about what's happening in large population centers around the world. It's important to recognize that this pandemic is affecting everybody. And it's affecting rural populations quite a bit, and it's definitely affecting our indigenous populations around the world. So I just wanted to make sure that we sort of ended thinking about that.
And I'd also like to add that because we went over and we don't have time for Q&A, if anybody who's a participant would like, who's observing this, would like to ask questions, me, Chris, Joe, Jordan, Justin, River, all have Lehigh email addresses. You can go into the Lehigh system to find us, and we can get you in touch with the other participants who don't have Lehigh emails. So if you have questions, please forward them to us. We will do our best to answer them and get you connected to who you need to be connected with. So at that point, I will turn it over to Fatima. Justin, I'm sorry. I apologize that you didn't get your time. You can start. Okay. Thank you, everyone. I appreciate your time and your participation. Fatima?
Thank you so much to our moderators and to all of our panelists for sharing your expertise and experiences with us today and for shedding light on this very, very important topic. I know that I have learned a great deal, and I'm sure our audience did as well. Thank you so much to all of you in the audience for joining us today. This session has been recorded, and the recorded session will be posted shortly. This is the last webinar for our summer COVID-19 webinar series, and what an excellent webinar to end with. So I would like to just remind you to please stay tuned for additional information regarding our upcoming fall webinars. And thank you so much again today, and I hope everyone has a wonderful day. Thank you.